بسم الله الرحمن الرحيم. هنتكلم النهاردة على موضوع مهم جدا which is dysmenorrhea. The definition of dysmenorrhea. Dys means pain. Dysmenorrhea means painful menstruation. How to define dysmenorrhea? Dysmenorrhea means painful menstruation severe enough to interfere with the normal daily activity of the female. It is one of the items of menstrual history, so we need to know what is the dysmenorrhea and how to differentiate between both types of dysmenorrhea, which is primary or spasmodic dysmenorrhea or secondary or congestive dysmenorrhea. The incidence of dysmenorrhea it is one of the most common gynecologic symptoms, represent from 30 to 75% of women complaining of these symptoms. It has a socio-economic impact as it forces about 10% of girls and women to miss 1 to 3 days of school or work every month. So it is a big problem. Types of dysmenorrhea: primary or spasmodic dysmenorrhea, secondary or congestive dysmenorrhea. Primary dysmenorrhea or spasmodic dysmenorrhea. It is painful menstruation in absence of gross pelvic lesion. Painful menstruation interfering with the normal daily activity of the female with absence of any gross pelvic lesion. So what is the cause of this dysmenorrhea? The definite cause is not present or unknown. It is just a theory. The most common theory of the etiology of spasmodic dysmenorrhea is increased in prostaglandin. So the first line of treatment of spasmodic dysmenorrhea is antiprostaglandin. Increased prostaglandin occur. The cause is progesterone withdrawal after degeneration of corpus luteum of menstruation in ovulatory cycle. Is supposed to increase prostaglandin F2 alpha and prostaglandin E2 24 to 72 hours before menstruation, resulting in repeated uterine cramps and uterine ischemia. This is the most common and the most accepted theory of primary or spasmodic dysmenorrhea. The second theory is uterine ischemia, when uterine pressure from contraction exceeds the main arterial blood pressure. Ischemia results with accumulation of acid metabolites which can stimulate pain neurons. The third theory is Mullerian anomalies occur in bicornate uterus, uterine hypoplasia, and congenital cervical stenosis, considered secondary dysmenorrhea by some authors. Psychological and behavioral factor. This is the most common theories of the cause of primary or spasmodic dysmenorrhea, but the most accepted theory is increased in the prostaglandin level. How to diagnose? Diagnosis of primary or spasmodic dysmenorrhea depend on many factors. It is by exclusion and symptoms and signs of this disease. Common age: patient usually virgin or nullipara of young age. Condition usually start 6 to 12 months after menarche with establishment of ovulatory cycles and improves spontaneously with age and marriage and disappear after vaginal delivery. So the common age after puberty with establishment of ovulation 6 to 12 months after menarche and before marriage. This is the common age group of this disease. Symptoms: pain. From its name, spasmodic, it is colicky pain, sharp and intermittent, usually suprapubic and may radiate to the inner aspect of the thigh. Start hours before or with the onset of menstrual flow and improved with the continuation of menstruation. Associated symptoms: nausea, vomiting, fatigue, low back pain, headache, dizziness, nervousness, and fainting attacks. By examination, no gross pelvic lesion. Investigation: ultrasound, hysteroscopy, laparoscopy. There is no any pelvic pathology. How to treat? Non-surgical treatment. General measure is reassurance of the girl or reassurance of the patient, as this is common symptoms occur after establishment of ovulation and it will disappear after marriage. Local heat, encourage exercise, narcotics, avoid constipation, and psychotherapy are needed in rare cases. Medical treatment. The most common and the most accepted line of treatment is prostaglandin synthetase inhibitors or antiprostaglandins. Action: it decreases endometrial prostaglandin, decrease uterine contraction. Types: the most common, methylenic acid, 250 mg TDS, or indomethacin, 25 mg TDS. Administration: started before the onset of pain or the onset of menstruation and continued for first few days of menses, to be repeated for at least 6 months before deciding failure of treatment. Efficacy: effective in more than 80% of cases. Combined oral contraceptive pills. As this dysmenorrhea, due to increase in the prostaglandin which occur after ovulation, we can prevent ovulation by use of combined oral contraceptive pills. Action: inhibition of ovulation, decreased prostaglandin release, and decrease in uterine cramps and ischemia. Indications: in cases needing contraception with no contraindication for combined oral contraceptive pills. Efficacy: it is effective in 90% of cases. Failure of treatment indicate possibility of presence of organic lesion and need further investigation. So this is the third line of treatment, COC, combined oral contraceptive pills, to prevent ovulation or to inhibit ovulation. Acupuncture and electric nerve stimulation. The second line of treatment is surgical treatment, and it is rarely needed. Dilatation of the cervix when there is cervical stenosis or other uterine anomalies, pre-sacral neurectomy, and laparoscopic uterosacral nerve ablation. Second type of dysmenorrhea is congestive dysmenorrhea. Congestive dysmenorrhea, painful menstruation interfering with the normal daily activity of the female, and presence of gross pelvic lesion. What is this lesion? It may be one of the following: pelvic endometriosis, adenomyosis, genital displacement, chronic PID, pelvic tumors, intrauterine or IUCD, sexual unsatisfaction, constipation, inflammatory bowel disease, or post-operative pelvic adhesions. How to diagnose? Age and parity. The common age usually multipara. Older age more than 25 years with history of previous painful cycles. Symptoms. From the character of this dysmenorrhea, the pain, congestive, dull aching pain, diffuse and constant in the lower abdomen and referred to the back. Starts few days up to 2 weeks before menstruation or menstrual flow, peaks just before flow, then gradual improved. Associated symptoms. Other symptom of pelvic congestion as dull aching pain, low back ache, dyspareunia, menorrhagia, and leukorrhea. Examination. The cause may be detected. Investigation, ultrasound, hysteroscopy, laparoscopy to detect the cause, as the cause is gross pelvic lesion. Differential diagnosis from other causes of chronic pelvic pain. Treatment is the treatment of the cause. So, dysmenorrhea means painful menstruation interfering with the normal daily activity of the female. It may be spasmodic or congestive. How to differentiate between both types? Spasmodic, the cause is unknown. It is just theories. The most accepted theory is increase in the prostaglandin in the second half of the cycle after ovulation. The type of the pain, it is usually from its name, colicky pain. Suprapubic colicky pain referred to the inner side of the thigh. It is occur with the onset of menstruation or few hours before menstruation and improved with continuation of menstruation. The age group usually start after establishment of ovulation. Girl, 6 to 12 months of establishment of ovulation, and usually improved after marriage. The treatment, antiprostaglandin, is the most effective treatment in this condition. The second type is congestive dysmenorrhea. From its name, it is a congestion. Congestion causes dull aching, deep-seated pelvic pain, usually deep in the pelvis and referred to the back. This pain occurs few days before menstruation and improved with the menstruation. Usually the cause is gross pelvic lesion as fibroid, endometriosis, adenomyosis, PID, intrauterine IUD, and so on. The treatment of congestive dysmenorrhea is the treatment of the cause. Membranous dysmenorrhea, type of spasmodic dysmenorrhea that occur as a result of shedding of endometrium in casts. Dysmenorrhea of endometriosis, pain start 2 days before flow, continue to increase gradually to peak with maximum flow, then begin to decrease gradually to disappear few days after cessation of bleeding, crescendo, decrescendo dysmenorrhea. The second type of dysmenorrhea in this lecture is premenstrual syndrome, PMS. This syndrome consists of many symptoms which occur in the second half of the cycle, in ovulatory cycle. This syndrome characterized by distressing cyclic physical, psychological, and behavioral symptoms that occur in late luteal phase of menstrual cycle and improve markedly by the onset of menstrual flow. Instance: 80% of women report PMS or premenstrual tension syndrome, and symptoms are severe enough to interfere with normal daily activity in only 5 to 10% of cases. 50 to 60% of women with PMS have underlying psychiatric disorder. The commonest age between 25 and 44 years. The etiology unknown. Disease of theories. The first theory is disturbance in neurotransmitters, deficiency of beta endorphin, vitamin B6, and serotonin. Endocrinal disturbance, high estrogen progesterone ratio, high prolactin level, and high aldosterone causing salt and water retention. Deficiency of essential fatty acid. This is the third theory. Prostaglandin level abnormalities. What is the symptoms of this PMS? Many symptoms. First, physical symptom in 40% of cases as headache, facial and peripheral edema, distension, bloating and weight gain, breast tension. The abdominal symptoms include bloating and weight gain with distension. Psychological symptoms, which is very common and very important, occur in 80% of cases, including tension, irritability, anxiety, depression, poor concentration, sleep disturbance, appetite changes, and libido changes. Behavioral symptoms in 20% of cases as suicidal tendency and suicidal attempts, criminal behavior. How to diagnose? It is difficult to diagnose. It is diagnosed also by exclusion because there are no specific symptoms or signs, but presence of normal ovarian function is essential for the diagnosis. It is occur in normal ovulatory cycle. History and physical examination to rule out organic lesion. Examination of patient diary of symptoms over period of 2 to 3 months. PMS should be suspected if symptoms occur in late luteal phase of cycle and improve markedly by the onset of the flow. Diagnostic tests: gonadotropin releasing hormone agonist administration for 3 months. Presence of symptoms during amenorrhea exclude PMS because it is related to ovulation. When we prevent ovulation, the symptoms must be disappeared in cases of PMS. But if it is not disappeared, it is not PMS. Treatment: general lines of treatment: reassurance and explanation, reduction of stress and prohibition of smoking, frequent small meals, exercise, limitation of alcohol, coffee and dark tea intake. This is general measures. Complementary therapy: vitamins and mineral, and evening primrose oil. Cognitive behavior therapy by psychotherapist in cases of severe PMS. Pharmacologic therapy: the first line is suppression of ovulation. Suppression of ovulation because the PMS occur in normal ovulatory cycle. Suppression of ovulation may be by combined oral contraceptive pills, one of the first line pharmacologic intervention, percutaneous E2 patches or implant, progesterone only contraceptive as dipomedroxyprogesterone acetate, implanon or POPs, progesterone only pills, gonadotrophin releasing hormone agonist, limited to short-term use to avoid long-term side effect as osteoporosis. The second line of pharmacologic drugs is selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitor is very essential in these cases, especially in severe cases which attempt suicide. It is an antidepressant drug. Other therapies: micronized progesterone, bromocriptine, diuretics, tranquilizer, benzodiazepines, and GABA. These drugs is complementary therapy, not specific, and its role is under research. Total abdominal hysterectomy and bilateral salpingo-oophorectomy rarely needed. It may be the definitive treatment in severe and resistant cases proved by gonadotropin releasing hormone agonist test. Thank you.